Here's a picture of the tonsils. You actually have 4 sets of tonsils. When we're talking about a tonsillectomy, we're usually talking about those palatine tonsils. They're the ones kind of at the back of your throat. The adenoids are also the same. They're a tonsil, actually, the same tissue, and they're up in the back of the nose. And here's a picture of tonsillitis, the swollen tonsils with a lot of white exudate on them. That looks like strep. Influenza. This is the flu. Everybody's had flu. You know the symptoms, the fever, the body aches. Often there's cough. You're just miserable. So it is a virus. It runs its course. The therapeutic management is to give the kids rest. That means grouping the activities. If a child ends up admitted, we don't want to keep waking them and doing stuff with them. Group our activities and let them rest in between. Make sure we're keeping them hydrated, lots of fluid, and then we can give Tylenol or ibuprofen for comfort and for fever. There are a few medications out there. The Simeritrol, this reduces the severity in influenza type A, but it has to be given within 24 to 48 hours of the onset. There's some other medications, zanamivir and ranitidine. These are inhaled, but also they don't kill the flu germ. They minimize the symptoms and they shorten the duration. So they lessen the severity, shorten the duration, but you have to start them early. They have to be started within 24 to 48 hours of the onset of symptoms, or it's too late. The flu's too far into its course to minimize it. When we had a lot of H1N1, Tamiflu was what they were giving kids who were diagnosed with H1N1, and that's oral. The big thing to remember is to not give aspirin. No ASA, that's acetylsalicylic acid. That's associated with Reye syndrome when a child has a viral illness. So kids under 16 with a viral illness, no aspirin. There is a vaccine available. You should have memorized your vaccine schedule. Kids over 6 months, they recommend an annual flu vaccine, which protects them against the 3 worst flus we're expecting that year. Otitis media. Kids between 6 months and 2 years get a lot of otitis media. Once they're 7, it's quite infrequent. By then the face is elongated, the eustachian tubes are longer and angled down, so it's rare after 7, but it's very frequent up to between 6 months and 2 years. Having smokers in the house keeps everything irritated, so it's a little swollen probably. It doesn't take much for it to become totally occluded from swelling. Bottle feeding. They're not getting the antibodies that you get from breastfeeding. Also, they tend to drink laying down. That eustachian tube is short and straight, coming out right there in the throat and back to the middle ear, so it's just they have more problems. The eustachian tube, which normally drains and ventilates the middle ear, your middle ear should have air in it. The eustachian tube lets air in, so air goes from your throat up into the middle ear, and any drainage that is produced in the ear, any serous fluid, can drain out. When you get some inflammation in there, now you can't move that air, drain any fluid out or move air in. So the air can't get in. The normal metabolism going on and with those cells around that middle ear use up the air that's in there. They start producing, well, and when that happens, you get negative pressure because we've used up the air inside that middle ear. It sucks back the eardrum, and you get kind of a negative pressure. So any bacteria that's in the throat is very likely to get sucked up into the middle ear because it's got negative pressure inside there. As that continues, those cells start to produce serous drainage. So now that can't drain out. We've got fluid in there. We've brought bacteria up from the throat, and it's the perfect situation for that bacteria to breed and grow and turn into a nice bacterial otitis media. Should you give antibiotics? we're finding a whole lot of antibiotics are becoming resistant to things, and most early ear infections, when it's still just serous, it's usually viral, and so the recommendation now by the Academy of Pediatrics is to wait 72 hours, unless the child looks acutely ill. If they're running a fever, they are laying there acting and looking sick, or if they're under 6 months, then we give them an antibiotic. Otherwise, if there's some fluid behind that eardrum, we know that eustachian tube's a bit swollen, they've got a viral illness going on, we don't necessarily give them antibiotics until it hasn't opened up and drained for in 72 hours, or they start to look acutely ill. Kids who have recurrent otitis medias, or they have one that we can never get under control and it's gone on for months, those kids will often get ear tubes, which is myringotomy, an opening. Otomy meaning an opening, myring being the eardrum, and then tympanoplasty, putting a little it's a little white plastic. It looks sort of like a grommet. It's bigger on the outsides to hold it in place and thinner in the center. So they make a little slit in the eardrum and stick that thing in that hole, lets the air in and lets any drainage out. Here's kind of just a picture of the anatomy there. And here again you can see the eustachian tube and why it's short and it's straight. It's easy for problems to develop, as opposed to the older child or the adult. It drains down. These are pictures of the eardrum. On the left is what it should look like. You should get that light reflex that you see about 4 or 5 o'clock there. The tympanic membrane is extremely thin. You can actually see the bones of the middle ear through it. On the right, this is an infection. It's red. I think in a clearer picture you can actually see it's bulged out because there's so much purulent drainage that's built up underneath there. Mononucleosis. It's an increase in mononuclear elements of the blood and just general symptoms of infectious process. It is common during the adolescent years. People often call it the kissing disease because it is transmitted by in saliva. You don't have to get it by kissing. The Epstein-Barr virus is the most common cause of it. That is everywhere. It's all over the place. When our immune system's lowered, then we're prone to catch it. It's an illness. We need to let it just run its course. It takes weeks for these kids to feel better, though. It looks like strep throat initially. You get very sore throat with big swollen tonsils with exudate on them. Does not respond to antibiotics, and in fact they tend to get a rash if you put them on the antibiotic and you say, oh, guess what, it's not strep throat, it's mono. The problem is hepatosplenomegaly. While they're acute, the spleen and the liver can become enlarged, so that's what you need to be watching and monitoring, and basically they just need to rest until they improve. Croup syndromes. These are in the throat, so they're characterized by hoarseness, a barking cough, and it sounds sort of like a seal. Arr, arr, arr. Inspiratory stridor, so you can hear them trying to inhale. And it's not a wheeze. A wheeze is out in the lungs. Stridor's in the throat, and you can hear it audibly when you're standing near the child. And then varying degrees of respiratory distress, depending on what it is. So croup syndromes are, like I said, in the throat. They can affect the larynx, the trachea, or the bronchi. Right there in that area is our epiglottis. The epiglottis opens and closes when we swallow, opens when we breathe. The epiglottis, when it swells up, that is an emergency, a medical emergency. It's life-threatening. The other things can be laryngitis, laryngeotracheal bronchitis, or tracheitis. Epiglottitis usually is between 2 and 8 years of old. That's the age kids get it. And the characteristics of it, the normal signs, are a rapid onset of sore throat, with pain, and you'll see them struggling to breathe. They have labored breathing where there's retractions. You're seeing the, it looks like in between the ribs suck in every time they take a breath. They're using those intercostal muscles. So you should suspect epiglottitis if the child's not coughing, but they are drooling and they seem agitated. When that epiglottis is swollen, they rarely have a cough, but they don't want to swallow, so they drool. And they're agitated because they're air hungry. They're not really breathing well. The therapeutic management for it, we're worrying about respiratory obstruction. That epiglottis can swell to the point that it totally occludes their airway. Look at the capitals. Do not inspect the airway. We can trigger total obstruction by inspecting the airway. They're taken to x-ray, and x-rays are done of the throat. You don't visually inspect it. Most of our epiglottitis are caused by the Haemophilus influenza B, which now has a vaccine. So that Hib vaccine has decreased the episodes of epiglottitis. And the treatment, like I said, you don't visually inspect it. You do lateral neck x-rays. It's usually bacterial, so it's treated with antibiotics. Can be treated with corticosteroids to try and bring down the swelling. You might have to intubate until we get that swelling down. Now, acute laryngitis. This is usually older kids and teenagers, and adults too. This is usually viral, and the chief complaint is hoarseness. You just have no voice. The larynx, where your vocal cords are, is swollen, doesn't work. It's usually self-limiting. Once the infection, the virus has run its course, the voice comes back, there's no long-term sequelae, and treatment is just symptomatic. If there's pain, you can do Tylenol for pain. It's just treating the symptoms. Now, acute laryngeotracheal bronchitis, this is the most common type of croup. This is usually kids who are less than 5, and this is usually, can be a lot of viruses, although mycoplasma too. RSV, parainfluenza, the mycoplasma, or influenza A and B. And manifestations you'll see of this are the stridor. You'll see retractions, usually suprasternal, so above the sternum. With every breath you'll see it suck in there. They have that barking seal-like cough, and they can have pretty significant respiratory distress. They can have hypoxia. This can progress to respiratory acidosis, respiratory failure, even death. Most of the time it's not that serious, but it can be. So management is airway management. We want to be sure we're assessing them, that we're doing accurate and continuous assessments of their airways. So if they start to get worse, we notice immediately. We want to maintain their hydration, whether that's oral fluids or IVs. High humidity usually helps. So if it's mild and they're at home, we can tell the parent to turn on the shower and go sit in the bathroom. But cool mist is usually better. So using the humidifier, and the cool one is preferred over the hot one. Another thing you can do is open the freezer door and kind of inhale that cool air. For some kids, however, cold air can be a trigger. So for those kids, the bathroom with the shower going is a better high humidity than the cool air from the freezer. So you kind of got to know the kid. It can be either. These kids are usually treated with nebulizer treatments, epinephrine, and steroids to bring down that swelling in the throat. And here's a picture of a mist tent, which we can blow in oxygen as well, but we're just blowing in humidity. We can also use these to blow in albuterol for our asthmatics, to give them continuous albuterol.